You know that specific, that low-grade anxiety you get when you're sitting on the crinkly paper in a doctor's office?
Oh, I know it well.
And you've got that poster of the human ear staring at you, the one that looks like a beige alien landscape, and the doctor walks in and just starts firing questions at you.
It can feel like a bit of an interrogation, right? Not a conversation.
Exactly. And half the questions feel weirdly irrelevant. You're there because your ear is throbbing, and they're asking, do you have stairs in your house?
Or what exactly is your job title?
Right. And you're thinking, are you diagnosing me or are you just being nosy?
This classic is, are you married? Which always raises an eyebrow.
Is this Hinge or a hospital? But today, we're going to flip the script on that entire experience.
We have a really fascinating document in front of us.
We do. It's a medical history taking guide, specifically for ENT ear, nose, and throat specialists. But honestly, it reads like a detective manual.
It really does. This document is essentially a training guide to take a rookie doctor and, turn them into a master consultant. It contrasts the wrong way to ask questions,
Which is casual, vague,
and unsafe, and it contrasts that with the right way, which is systematic, quantified, and safe.
And that's our mission for this deep dive. We're going to decode the hidden logic behind those seemingly random medical questions. We want to turn you, the listener, into an informed patient who understands that precision in language isn't just semantics.
It can literally save a life. We're going to see that what sounds like small talk is actually high-stakes data collection.
So let's start at the very beginning of this guide, the bio data. This is the boring stuff, the top of form, name, age, address. The guide explicitly calls out the wrong way to ask where someone lives. Apparently, just asking where do you live is a rookie mistake. Why is that not enough?
It's all about specificity and safety. A rookie asks, where do you live? And the patient says, oh, I live downtown.
Which is conversational.
It is, but it's useless in an emergency. The consultant asks, can you provide your complete address, including the postal code?
That just sounds like bureaucracy, though. Paperwork.
It feels like it, but the guide points out this is a safety net. In ENT specifically, we deal with infections that are millimeters away from the brain. If a patient has a malignant ear infection or a brain abscess, and they don't show up for a follow-up,
Oh, wow.
I live downtown doesn't help me send an ambulance or the police to check on them.
So it's about trackability in a life or death scenario.
Exactly. And that logic extends to the marriage question. The guide admits asking, are you married, can seem intrusive.
A little judgmental even.
It can be. So the right way is to explain why you are asking. You say, what is your marital status? I ask because this helps us understand your support system at home.
That lands very differently. It turns it from a personal probe into a logistical question.
Because it is logistics. If I'm about to perform a mastoidectomy, which is a major surgery where we drill into the skull bone behind the ear, you're going to be dizzy, nauseous, and bandaged up afterwards.
Right.
I need to know, is there someone there to change that dressing? Is there someone to catch you if you walk into the bathroom?
And if the answer is no, I live alone, does that actually change the medical plan?
Oh, completely. It changes the entire admission. We might keep you in the hospital for 3 days instead of sending you home same day.
Yeah.
We have to build the care plan around the reality of your life, not just your ear.
That makes perfect sense. The guide also emphasizes occupation. And I like this part. It links the job to the etiology, the cause of the disease. But it's not just about noise.
No, noise is the obvious one. You work in a factory, we check for high-frequency hearing loss. But a detective looks closer. If you're a diver or a pilot, I'm thinking barotrauma.
Pressure injuries.
Pressure injuries, because of Boyle's law, right? If you descend too fast, that pressure vacuum can rupture blood vessels in the middle ear. But think about a teacher or a call center employee. They present with a sore throat. I'm not thinking virus immediately. I'm looking for vocal nodules. They're voice professionals.
They use their vocal cords like an athlete uses their hamstrings.
Precisely. The occupation hands you the diagnosis before you even pick up the instruments.
So we've established the background. Now we get to the reason the patient is actually there, the presenting complaint. The guide has a golden rule here. Capture the complaint in the patient's own words.
This is so much harder than it sounds. Doctors love to translate things into Latin immediately to feel smart.
Of course.
So a patient says, my ear feels like it's underwater. And a rookie writes, eustache and tube dysfunction.
But isn't that just efficient? You're skipping to the answer.
You're skipping to a bias. By translating it too early, you stop listening for other clues. You need to write down feels like underwater, because later, that specific description might distinguish between fluid behind the ear
Which is common.
and sudden sensorineural hearing loss, which is an emergency. The patient's metaphor is often more accurate than the doctor's Latin.
Okay, so keep it raw. But then you have to analyze those words. And this is where the guide gives us these incredible mnemonics.
The flight checklist.
Yes. The first one is for ear discharge. The medical term is otorrhea. And the mnemonic is S-I-C-K-A-T. Let's break this down.
SICKAP is brilliant. S stands for start or several episodes. This is about the history. Is this new or is this a recurring nightmare?
And why does that distinction matter so much?
Because a one-off discharge is usually an acute infection. You went swimming, you got a bug, we treat it, it's gone. But if you tell me, doc, my ear has been leaking on and off for 10 years,
10 years.
that is a massive red flag for a chronic disruptive disease, like chronic suppurative otitis media. It implies the bone is likely being eroded. Acute happens to soft tissue. Chronic happens to bone.
That is a scary distinction. Okay, moving to eye itching.
Itching is a great differentiator. If your ear hurts and it itches like crazy, it's almost always otitis externa, swimmer's ear.
So it's a skin infection in the canal.
Right. And the skin of the ear canal is highly sensitive, like the skin on your arm. But the middle ear behind the drum is lined with mucosa, like the inside of your mouth. It doesn't itch the same way. It aches.
That's a handy shortcut. Okay, C is for character. The guide warns against vague terms like gooey stuff.
Oh, yeah. The character of the fluid is forensic evidence. Is it clear and watery?
That sounds clean. Good break.
No, that's terrifying. Clear often means cerebrospinal fluid, CSF.
Wait, brain fluid.
Brain fluid. It means there's a crack in the skull base, and the fluid bathing your brain is literally leaking out of your ear.
Okay, point taken. Clear is bad.
Got
What about a smell? The guide mentions foul smelling.
And I mean room-clearingly bad. That specific smell is the hallmark of a cholesteatoma. It's a skin cyst that grows into the middle ear, and the smell is from anaerobic bacteria thriving on decaying bone debris.
Wow. So the smell is literally the scent of bone destruction.
It is. A master consultant smells the diagnosis walking into the room.
Moving on to K. The guide uses a Hindi phrase here, kia occurrence, but it translates to aggravating factors.
Just cause and effect. Does getting water in the ear trigger it? That points to a hole in the eardrum. Does a cold trigger it? That points to the connection between the nose and ear.
The eustachian tube.
Exactly. And finally, T for treat. Have you used drops?
This is the resistance check.
Right. If you've been using antibiotic drops for a month and it's still leaking, the bacteria have likely outsmarted the drug. Or we're treating the wrong thing entirely, like a fungus, which actually loves antibiotics.
So SRCAT turns a vague, leaky ear into a precise list of suspects. Okay, let's move to the symptom that I think is the most confusing for everyone. Dizziness.
The black hole of diagnosis. It's the most imprecise word.
The guide basically said the word dizzy is medically grammatically useless. You have to just strip that word away.
You have to. Dizzy can mean I feel faint, which is a heart problem. It can mean I feel off balance, a nerve problem. Or it can mean the room is spinning, which is an ear problem.
And the guide uses the mnemonic SOFIAT here. S is for that exact distinction. Spinning versus swaying.
This is the fork in the road. True vertigo is a hallucination of movement. You are sitting still, but your brain thinks you are cartwheeling. That is almost always the vestibular system in the inner ear.
So room spinning, look at the ear. Feel like passing out, look at the heart.
As a general rule, yes. Now the O in SOFIAT is onset and duration. The guide calls duration the single biggest clue, and this is what I want you to really grasp.
The clock.
The clock. The amount of time you are dizzy literally tells us the name of the disease.
Okay, run the timeline for us. What if it lasts for seconds?
If you roll over in bed, look up at a shelf, and whoosh, the world spins violently but stops after 30 seconds. That is BPPV.
Benign paroxysmal positional vertigo. The crystals.
The crystals. Exactly. You have these tiny calcium crystals in your ear that get loose and fall into the wrong tube. When you move your head, they roll around and confuse your balance nerve, but gravity settles them down in about 30 seconds, so the spin stops.
So a brief spin equals a mechanical problem. What if it lasts for minutes or hours?
If it's 20 minutes to a few hours and it comes with roaring tinnitus and hearing loss, that is the classic presentation of Meniere's disease.
What's the mechanism there? Why hours?
Meniere's is a fluid pressure problem. Think of it like glaucoma, but in the ear. The fluid builds up, causing immense pressure in the vertigo until the membrane ruptures or the fluid reabsorbs. That hydraulic process takes hours.
That makes perfect sense. And if it lasts for days?
If you wake up vomiting, the world is spinning and it doesn't stop for 3 days straight. That's usually vestibular neuritis. A virus has inflamed the balance nerve itself. It takes the brain days to compensate for that.
So I was dizzy for a minute versus I was dizzy for a week are two completely different universes.
Completely. One is a loose crystal, one is a viral attack. And that's why if a patient says, I'm dizzy all the time, a consultant will dig and dig until they find out exactly how long the attacks last.
Let's talk about the company Dizziness Keeps. The H in SOFIAT is headache and hearing loss.
Right, connecting the dots. If you have a severe headache plus vertigo, you might have a vestibular migraine. Many people don't realize migraines aren't just pain, they can be a storm in the brain that affects the balance centers.
Speaking of hearing loss, there's a fascinating section called the sounds of silence. The guide distinguishes between losing volume and losing clarity.
This is so crucial. A patient might say, I can hear that you're talking, but I can't understand the words. It sounds like mumbling.
What does that indicate?
We call it the cocktail party effect. If you struggle to distinguish speech from background noise, it usually means the nerve or the processing center in the brain is damaged. It's retrocochlear behind the cochlea.
And then there's the opposite, hyperacusis.
When normal sounds hurt, someone slams a door and you wince in physical pain. That suggests damage to the cochlea itself. The shock absorbers of the ear are broken.
Now tinnitus, the ringing. The guide divides this into subjective, what most people have, and objective. Objective tinnitus. The doctor can hear it.
It sounds like science fiction, but yes, if I put a stethoscope on your skull or near your ear, I might actually hear a sound coming from your head.
What are you hearing?
Usually turbulence. If I hear a whoosh whoosh perfectly in time with your heartbeat, that's pulsatile tinnitus. It means there is turbulent blood flow near the ear.
Like a kink at a garden hose.
Exactly. It could be a blocked artery or a vascular tumor. It needs investigating immediately.
And sometimes you hear a clicking sound.
Yes, that's usually a muscle spasm myoclonus, like a twitching eyelid, but inside the middle ear, the tiny muscles are just snapping.
Okay, we've covered the symptoms. Now we need to talk about the scary stuff, the red flags. The guide uses the mnemonic FPML.
These are the exam failure points. You miss one of these in medical school, you fail. In real life, the consequences are obviously much higher.
Let's go through them. F is for facial weakness.
This is the most dramatic one. The facial nerve, which controls your smile, your eyelid. It runs right through the middle of the ear. If you have an ear infection and suddenly half your face stops moving, it is a surgical emergency.
Because the infection has reached the nerve.
It's compressing it. It swells inside that tiny bone tunnel and strangles itself. You have to decompress it immediately or the paralysis could be permanent.
Wow. P is for petrositis. This involves great and ego's triad.
A terrifying condition. It means the infection has burrowed deep into the petrous apex, which is the hardest bone in the body, right at the center of the skull base.
And the triad is ear discharge, pain behind the eye.
And double vision.
Pain behind the eye from an ear infection. That seems like a huge jump.
It shows the geography of the invasion. The infection has marched so deep into the skull that it's hitting the abducens nerve, which controls eye movement. If your ear infection is causing double vision, the bacteria are winning.
That is a massive red flag. M is for meningitis.
Most people know these signs: stiff neck, light sensitivity. It means the infection has breached the dura, the lining of the brain.
And finally, L. labyrinthitis or mastoiditis.
And this one is visible. You can see the ear literally being pushed forward and down. There's so much pus and swelling in the mastoid bone behind the ear that it physically displaces the whole thing.
Okay, deep breath. Those are the immediate dangers. But the guide also talks about risk factors. The mnemonic is drains.
Drains cover systemic issues. D is for diabetes. For ear doctors, this is huge. Poorly controlled diabetes can lead to something called malignant otitis externa.
That word malignant usually means cancer.
Here it acts like cancer. It's a necrotizing infection where the tissue just dies and turns black. It spreads rapidly into the skull base and has a high mortality rate.
R is for renal kidney failure. I was surprised by this one. Why do ear doctors care about kidneys?
It's all about the drugs. Many strong antibiotics, like gentamicin, are cleared by the kidneys. If your kidneys are weak, they can't flush the drug out.
So it builds up to toxic levels.
Exactly. And it destroys the hair cells in the ear. It's called ototoxicity. We always check kidney function before prescribing those heavy hitters.
S is for smoking. The guide mentions pack years.
It's a calculation. Packs per day times years smoked. It just quantifies the damage. For a surgeon, smoking is a nightmare. It kills the microblood supply. If I try to patch your eardrum with a skin graft and you smoke,
The graft won't take.
it starves and dies.
And we can't forget the social history. The guide brings up the CAGE questionnaire for alcohol.
CAGE is a subtle way to screen for dependency. C. Have you ever felt you should cut down? A. Have people annoyed you by criticizing your drinking? G. Have you felt guilty?
Andy,
E. Have you ever had a drink first thing in the morning as an eye-opener?
why is the eye opener the critical one?
Because it implies withdrawal. It means your body physically needs alcohol to function. For a surgeon, that's terrifying. If I put you under anesthesia, you can go into acute withdrawal during recovery. Seizures, delirium. It's not a moral judgment. It's about keeping you alive.
It all comes back to safety. Okay, so we've gathered all this info. The CCAT, the SOFIAT, the drains. Now we treat. The guide is a philosophy here. Examine before investigating.
Yes. Don't just order a CT scan from the doorway. Look in the ear. A simple look with a microscope can save thousands of dollars and unnecessary radiation.
And the treatment starts conservative.
Always. Take BPPV, the crystal dizziness. We do the Epley maneuver. We physically roll your head in a specific sequence to guide the crystals back where they belong. It has a 90% success rate. No pills, no surgery, just physics.
But sometimes you need meds fast. The guide mentions a steroid emergency. I think this is a vital PSA for everyone.
Absolutely. If you lose your hearing suddenly, like someone hit a mute switch on one ear, you have a 72-hour window.
Only 72 hours.
It's the golden window. This is sudden sensorineural hearing loss. It's basically a stroke of the ear nerve. If you get high-dose steroids within 72 hours, you have a good chance of saving your hearing. If you wait 2 weeks thinking it's just wax,
Could be gone forever.
it might be, so do not wait. Go to the ER.
That's a huge takeaway. And finally, surgery. We talked about mastoidectomy. The guide mentions 2 types, canal wall up and canal wall down.
It's like a home renovation, really. In canal wall up, we clean out the infection but leave the wall of the ear canal standing. Your ear looks normal and you can swim, but there's a risk the disease is hiding.
And canal wall down.
That's the nuclear option. We drill down the wall, creating a single large mastoid bowl. It's safer because the disease has nowhere to hide, but it means you have a big open cavity that needs professional cleaning for the rest of your life.
It's a trade-off between absolute safety and lifetime maintenance.
Medicine is always about trade-offs.
And ultimately, the guide ends on rehabilitation. It's not just about fixing the hole or killing the bacteria.
It's about quality of life. If I stop the infection but leave you deaf and dizzy, I haven't really won. Rehabilitation hearing aids, tinnitus retraining, vestibular therapy. That's how we get the patient back to being a person.
So bringing this all together, we started by asking why the doctor wants to know if you have stairs. And we've ended up deep inside the skull bone, debating crystal physics and kidney function.
That is the journey of a diagnosis.
What I love about this guide is that it shows the consultant mindset. It's not about memorizing facts, it's about connecting the dots.
It's about quantifying everything. A rookie hears, I'm dizzy. A consultant hears, spinning, lasting seconds, triggered by rolling over. The consultant builds a safety net with every specific question.
So for everyone listening, the next time a doctor asks you a weirdly specific question, does the room spin? Is the ringing like a heartbeat? Don't just say yes or no.
Recognize that they are trying to slot your symptom into a precise physiological box. They are checking for those red flags we talked about.
And here's a thought to leave you with. We often think of modern medicine as high-tech scans, MRIs, and robot surgeries. But this guide suggests that the most powerful tool in medicine is still language.
A specifically worded question is often more powerful than an MRI.
If we all learn to describe our symptoms using SICAT or SOFIAT, if we walked in and said, Doc, I have true vertigo lasting seconds triggered by looking up, how much faster could we be healed?
That would be a doctor's dream.
Something to think about before your next checkup. Thanks for diving deep with us today.
Stay curious.
And stay healthy. We'll see you next time.